All right, it looks like we're at a bit of a steady state, so we'll get started. Good morning, everyone, and welcome to our Calgary Emergency Department Grand Rounds. My name is Katie Lynn. I'm one of the emergency physicians at Foothills and PLC. Thanks for joining us this morning. I have the distinct pleasure today of introducing our presenter, Dr. Sean Crooks. Not only is he one of our PGY3 Emerge resident superstars, he's also an ex-Olympian extraordinaire with a VO2 max of over 9,000. So Sean will actually be taking us through an evidence-based journey of diagnostic workup for subarachnoid hemorrhage in the emergency department. Before we begin, I'd just like to remind everyone about the Q&A box in the bottom right-hand corner of your screens. Please feel free to submit any questions throughout the talk, and I'll help moderate the Q&A session at the end of Sean's presentation. And also a quick note that Doctors Sean Dowling and Neil Collins will be presenting briefly on the MyED app at the end of the talk, sort of at about 10 a.m. So remember to stick around for that as well. Finally, just a quick note of positive vibes towards our R5s who are writing their exams today. So without further ado, please welcome Dr. Sean Crooks. And Sean, take it away.
Thank you, Katie. And thanks everyone for tuning in this morning. So non-traumatic subarachnoid hemorrhage is a devastating diagnosis that carries significant mortality and morbidity with it. Over the past 10 years, there's been an evolution in the diagnostic workup for subarachnoid hemorrhage, with multiple attempts to create and simplify an algorithm. And one of the drivers of this evolution has been a series of landmark studies, many out of Ottawa, which have deepened our understanding of this diagnosis. Classically, the workup for suspected subarachnoid hemorrhage has been to CT and LP to rule it out definitively. This classic algorithm seems beautiful in its simplicity, but like an ancient sculpture that looks beautiful from a distance, if you start to look closely, you may start to see cracks and imperfections. And that's what we're going to do today. Let's look closely at the algorithm for the diagnostic workup of subarachnoid hemorrhage. Subarachnoid hemorrhage has been called a black swan diagnosis, a needle in a haystack, or like trying to find Bernie Sanders in this picture. It is a low frequency, high acuity diagnosis, and it can be challenging for us to find the subarachnoid hemorrhages among all the headache patients we see in the emergency department. Even among patients that present to the ED with a classic thunderclap headache, less than 10% of these patients are ultimately diagnosed with subarachnoid hemorrhage. Subarachnoid hemorrhage presents with a spectrum of severity, from the subtle isolated headache to the patient with neurodeficits, altered LOC, and even cardiac arrest. The patients we're going to focus on today will have more subtle presentations. These are the smaller bleeds that are still at risk for rebleeding. The subtle subarachnoid can be challenging to diagnose in the ED, and we actually miss up to 5% of these on initial presentation. Subarachnoid hemorrhage has an extremely high mortality and morbidity. These patients are younger than average stroke patients with an average around 40 to 60 years old, so they have more productive years lost than stroke patients usually. And 50% of subarachnoid hemorrhage survivors actually never return to work. The mortality is 50% in the first 2 hours, 40% in the first week, and 70% if a patient re-ruptures. 80% of subarachnoids are aneurysmal in origin, and that's what we see in this picture here. So what happens in aneurysmal subarachnoid is bleeding releases directly into the CSF under arterial pressure, and the blood spreads quickly within the CSF and rapidly increases intracranial pressure. The other 15% of subarachnoids are non-aneurysmal in origin, such as perimesencephalic hemorrhages, which have a more benign course and often do not require surgery. The final 5% are more rare etiologies, such as AV malformations, dural AV fistulas, mycotic aneurysms, or secondary to recreational stimulant drug use, mainly methamphetamines and cocaine. There are also traumatic causes of subarachnoid hemorrhage, which we won't be discussing today. The most common risk factors for subarachnoid are smoking, hypertension, and genetic risk. So patients with polycystic kidney disease or family history of aneurysm or Ehlers-Danlos syndrome. So classic teaching characterizes the headache of subarachnoid hemorrhage as a thunderclap headache, which is defined as a sudden, severe headache, often described as the worst headache of a patient's life. So for the talk and in the literature, there are really two definitions of thunderclap headache we're going to use. So the first we're going to call thunderclap headache light, which is a severe headache that peaks within 1 hour. So this ultra-conservative definition is used by the recent literature as inclusion criteria in order to ensure we're not missing any cases of subarachnoid hemorrhage. The second definition is a true thunderclap headache. That's a 1 second to peak, bang, headache that peaks within 1 second. So intuitively, this type of headache seems like it should be much more worrisome for subarachnoid hemorrhage. But as we're going to see, it doesn't have as large of an effect as we would think on increasing the probability of subarachnoid hemorrhage. Just remember, subarachnoid hemorrhage is not the only cause of thunderclap headache. Other important causes include the sentinel headache of subarachnoid hemorrhage, which has also been called a warning leak. So this thunderclap-like headache occurs in the days to weeks prior to a subarachnoid hemorrhage and has been reported in up to 60% of patients who eventually are diagnosed with subarachnoid. The second common cause for thunderclap headache is RCVS, or reversible cerebral vasoconstriction syndrome, which is a fairly new term used to describe a group of disorders that cause reversible narrowing and dilation of the medium-sized cerebral arteries. Reversible cerebral vasoconstriction syndrome causes a recurring thunderclap-like headache. So under the RCVS umbrella are previous diagnoses like postpartum cerebral angiopathy, CNS pseudovasculitis, drug-induced cerebral arteritis, and others. RCVS can be seen on CT angiogram, and RCVS can have complications like stroke and seizure, but has a much better prognosis than subarachnoid hemorrhage. Other worrisome causes of thunderclap headache that we're more familiar with would be like intracerebral hemorrhage, vascular dissection, so vertebral and carotid dissections, CVST, which is something we've heard about recently quite a bit in the media, cerebral infections, and complications secondary to hypertension. So after reviewing this topic, this is the first section, or the first part of a proposed algorithm I've created for the diagnostic workup of subarachnoid hemorrhage that we're going to discuss today. Similar algorithms have been published recently in the EM literature. So the hot topics we'll discuss today are: first, can we avoid this algorithm altogether and rule out subarachnoid hemorrhage before a non-con CT by using the Ottawa subarachnoid hemorrhage rule? Second, what patients can we rule out subarachnoid hemorrhage after a negative non-con CT? And how do we risk stratify these patients to make that decision? And lastly, after a negative non-con CT, if we're still worried about subarachnoid hemorrhage, what's our next step, a CTA or an LP? So let's begin with a case that we'll use to navigate through our workup. So you're seeing a healthy 41-year-old female with a sudden severe headache at work. She describes it as the worst headache of her life, and it peaked within 10 minutes. She had to sit down when it began. She'd had headaches previously, but this one was different and much more intense. She took a couple of acetaminophen, and when the pain was not relieved, she presented to the emergency department. She has nausea, but no vomiting. She has neck stiffness subjectively, but no objective neck stiffness when you ask her to flex her neck. Her vitals are normal. She's alert, oriented, and with a normal neurologic exam. She presents to triage 5 hours post-headache onset, and she waits in the waiting room for 2 hours. So by the time you see her, it's been 7 hours. So from our algorithm, the first question we ask is, can we rule out subarachnoid hemorrhage before a non-con CT scan using the Ottawa subarachnoid hemorrhage rule? So the Ian Steele and Jeff Perry group in Ottawa have been working hard over the last 10 years to develop a tool to lower the number of workups we do for subarachnoid hemorrhage. This tool is a one-way decision instrument similar to the PERC rule, and states that patients require further investigation, which implies a non-con CT, if they have one or more of the following findings. To apply the rule, patients must be neurologically intact, alert, over the age of 15, with a new severe atraumatic headache that peaked within 1 hour. So remember, that's our thunderclap light headache. You cannot have a prior aneurysm, you can't have a prior subarachnoid, you can't have a brain tumor, and you can't have a chronic recurring headache of similar nature 3 times in the last 6 months. Then you can apply the rule. So patients require further investigation if they have one of the following findings: neck pain or stiffness, age greater to or equal to 40, witness LOC at the time of the headache onset of headache during exertion, thunderclap headache. So just to clarify, you need a 1 hour to peak headache as inclusion criteria. So a thunderclap light headache as inclusion criteria, but a 1 second to peak headache gives you a positive. And then limited neck flexion on exam. So that's defined as unable to touch your chin to your chest, or unable to lift your head off the bed 8 centimeters if you're lying supine. So our patient, in our case, she met the inclusion criteria, but she's 41. And she has subjective neck stiffness. So she has 2 positives that suggest further workup. But remember, you only need 1. So her being 41 alone would have been enough to pursue further diagnostics. So how did the Ottawa rule come to be and how does it perform? So to date, the Ottawa subarachnoid hemorrhage rule holds 100% sensitivity for ruling out subarachnoid in over 7,000 patients in 4 countries. Technically, the rule has been externally validated, but those external validations occurred in the same sites as the internal validation and derivation studies. So you can take that with a slight grain of salt. But there are 4 prospective studies that went into the development of this rule. And all of them, except for the 2016 BMJ study from Japan, are from Ian Steele and Jeff Perry. And what you will notice is that when this rule is applied, the sensitivity is 100%. The specificity, though, is consistently very low, which is probably its biggest shortfall and maybe leading to more testing and more consideration of the diagnosis of subarachnoid hemorrhage. So let's talk about this further. Let's have a closer look at the rule, looking at the good merits. So the rule has been externally validated on our population, Canadian population, and it is very sensitive with tight confidence intervals. So in patients that screen negative for this rule, you can document on your chart with confidence that the patient's Ottawa subarachnoid hemorrhage rule negative, similar to the PERC rule, and then you're done your workup. And it also serves as a reminder of the high-risk features are really the independent predictors of subarachnoid hemorrhage. But if we look at the rule with a skeptical eye, we can see some imperfections. So there are some subjective inputs into the rule, such as headache on exertion, subjective neck stiffness, and instantly peaking headache. And instantly peaking headache has very high interobserver variability. The poor specificity of the rule is probably the biggest issue. The rule may be making us consider the diagnosis of subarachnoid hemorrhage in more patients than before. So a 1 hour to peak headache inclusion criteria will capture many patients in the emergency department. And then with age cutoffs as low as 40 for a positive, you may start to feel the need to investigate for subarachnoid hemorrhage in more patients than you would have previously. In the studies, only a small number of patients actually screen negative for this rule once they've met the inclusion criteria. So in the Stroke 2020 Perry article and the CMAJ 2017 Perry article, in both those studies, 88% of patients who met inclusion criteria screened positive for the rule and had a CT scan. So when you apply the rule, there doesn't seem to be very many patients that actually screen negative. The rule has never been shown to reduce the number of CT scans and hasn't been tested against clinical gestalt. So what's the bottom line with the Ottawa rule? The Ottawa rule is a blunt instrument that lacks specificity. It's a good reminder of the most worrisome clinical features of subarachnoid hemorrhage. And in some instances, you'll get lucky and your patient will screen negative and you've ruled it out. But the rule is not the solution to lowering our number of CT scans, and it may actually end up increasing the numbers as we're considering subarachnoid hemorrhage in more patients than before. Interestingly, though, the studies that went into the derivation and validation of this rule have given us a robust data set to predict the chance of subarachnoid hemorrhage, which leads us to the next section of the talk. So as we know, emergency medicine is a game of numbers, and we're always making probability calculations on patients. In subarachnoid hemorrhage, we have enough data on its clinical features that we have a pretty good idea of a patient's probability of diagnosis based on clinical features using a Bayesian approach. So instead of using a blunt instrument like a one-way tool to decide whether to pull the trigger on a non-con CT or later on an LP or CTA, we can accurately estimate the probability of subarachnoid hemorrhage in patients in order to risk stratify them. So there are 2 features that should always make us think about subarachnoid hemorrhage. So this is a 1 hour to peak headache and worst headache of life, as all the patients in the Perry papers had at least one of these features. The issue is these features will also capture a large number of patients with other causes of headache. So if we look at the data another way, here's a graphic representation of the most common clinical features of subarachnoid hemorrhage of all patients that present to the ED with a thunderclap light headache. So remember, 1 hour to peak severe headache. So the red represents the subarachnoid hemorrhage patients, and the gray is all other causes of headache. So what you can see is in isolation, none of these clinical features are overly predictive of subarachnoid hemorrhage. And actually, all of them are much more likely to be present in patients without subarachnoid hemorrhage than with. This is because subarachnoid hemorrhage is quite a rare diagnosis. So the power only really comes from combining these features. So before we start combining features, I want to do a quick refresher on Bayesian statistics. So recall that in Bayesian statistics, you have a pretest probability, aka the prevalence of disease, and then you factor in a positive or negative likelihood ratio to either increase or decrease your post-test probability. And we use a normogram for this. Recall that a positive or negative likelihood ratio of 1 does not alter your post-test probability. If you have a positive likelihood ratio of under 5, it has a moderate increase on post-test. 5 to 10 has a small increase on post-test. 5 to 10 has a moderate, and then over 10 has a large increase on post-test probability. In negative likelihood ratios, the smaller the number, the more powerful it is to lower your post-test. So 0.2 to 0.5 has a small decrease in post-test probability. 0.1 to 0.2 is a moderate, and under 0.1 is a large decrease on post-test. So let's try it. In the Bayesian approach, we first have to get a sense of what the pretest probability for subarachnoid hemorrhage is for all patients presenting to the emergency department. So of all headaches that come to the emerge, it's about 1% chance of subarachnoid. In 1 hour to peak thunderclap light headaches, the prevalence is 7.5%. So how does the probability change with a 1 second to peak headache or worst headache of life? So as we learned before, those features are sensitive, but they're not specific as they're so common in other headache etiologies. They have a positive likelihood ratio of just around 1, which actually doesn't alter our post-test probability, which is surprising because you'd think a 1 second to peak headache would have a large effect on post-test. You can see that using our normogram, the pretest starts at 7.5%, and then we run a line through the likelihood ratio of 1, and then our post-test is still 7.5%. So that wasn't overly helpful. So these two features should trigger us to always think about subarachnoid hemorrhage, but they don't change our probability at all. So the question is, what factors do change our probabilities? Well, on this table, we have a list of the top 7 clinical features with the highest positive likelihood ratio for subarachnoid hemorrhage. And what you'll notice is many of these features are the same features from the Ottawa subarachnoid hemorrhage rule, as they are the independent predictors of subarachnoid hemorrhage. You can see that objective neck stiffness has an impressively high likelihood ratio of 7. The likelihood ratio is 4 for subjective neck stiffness, 3 for focal deficits, and 2 for age over 40, witness LOC, exertion at onset, and vomiting. So let's consider our case. So she had a pretest probability of worrisome headache of 7.5% because she had a 1 hour to peak headache. She is over the age of 40, so that brings her up by 15%. She has subjective neck stiffness, so that brings her up by roughly 25%. So at this point, she has a roughly 50% chance of having a subarachnoid hemorrhage before a CT scan. But we can't forget to take into account negative likelihood ratios. So here's a list of the top 4 negative likelihood ratios for subarachnoid hemorrhage. So if you're under 40, it's not the worst headache of your life, peaked over an hour, and you're not vomiting, those significantly bring down your post-test. So in her case, she wasn't vomiting. So that brings her down by 15%. So now she has a probability of 35% for subarachnoid hemorrhage. So let's just review all that again. So her pretest probability for worrisome headache was 7.5%. She's over 40, so it brings her up by 15. She has subjective neck stiffness, brings her up by 25. And then she's not vomiting, so it brings her down by 15. So she's now at 35%. So that was a lot of info. So with some help, I've created a website that will soon to be an app to help calculate the probability of subarachnoid hemorrhage pre and post non-con CT and pre and post LP and CTA. So if you scan the QR code on the screen there, it will take you to the app. So I'll give you a second to do that if you guys like. So the likelihood ratios on the calculator come from the Chris Carpenter meta-analysis from Academic Emergency Medicine in 2016 that posted likelihood ratios for all the clinical features of subarachnoid hemorrhage. The Carpenter paper uses mainly the Perry data for its data source. And I emailed Chris Carpenter about this idea of having a calculator, and he was supportive of the idea as a prototype for further study. So you can see the data we obtain as clinicians on history and exam for subarachnoid hemorrhage is incredibly powerful and will help us later on in our decision whether or not to CTA or LP. So let's summarize. Consider the diagnosis of subarachnoid hemorrhage in patients with 1 hour to peak headache or worst headache of life. These patients have a 7.5% chance of subarachnoid hemorrhage. The 1 hour to peak headache is very conservative and ensures we're not missing any potential cases. You can use the positive and negative likelihood ratios to determine your level of concern. Remember that neck stiffness, focal deficit, age over 40, loss of consciousness, exertion onset, and vomiting increase your post-test significantly. Use the auto rule as a rule out or reminder of the worrisome features, or use the calculator I created to determine your pre-CT probability of subarachnoid hemorrhage. Okay, so for the next section of the talk, we're back in Ottawa for round 2. The 6-hour head CT rule is the second rule to come out of Ottawa when it comes to subarachnoid hemorrhage. The rule states that a non-con CT done within 6 hours of symptom onset can rule out subarachnoid hemorrhage without the need for further investigation. So up until 2011, there had been no prospective studies of emergency department patients with acute headache involving modern CT scanners. That was until Perry published his landmark prospective multi-centered study in the BMJ in 2011 that demonstrated 100% sensitivity for identifying subarachnoid hemorrhage when performed within 6 hours of symptom onset and interpreted by a radiologist. So in that study, they had 121 patients with subarachnoid hemorrhage, and the non-con CT under 6 hours didn't miss a single one. The Perry paper changed the way subarachnoid hemorrhage was worked up in the ED. So before this study, CT followed by lumbar puncture was the gold standard. So after this game changer study, that if you could get the scan done within the 6-hour window, subarachnoid hemorrhage was considered ruled out. It almost seemed too good to be true. But as we know, nothing in medicine is 100%. So the first dent on the new car came in 2016, when Dubois and colleagues performed a systematic review that looked at 5 trials and 9,000 patients and concluded that a CT scan within 6 hours of symptom onset had a sensitivity of 98.7%. So still very good. So they had 9,000 patients and they had 13 misses. Then in 2020, we got a reality check from Perry himself when he published a follow-up study in stroke to look to validate the 6-hour CT rule. This was really the paper that inspired this talk, as it showed us a more believable sensitivity for subarachnoid hemorrhage within the 6-hour window. So this time around, they found non-con CT within 6 hours of headache onset to be 95.5% sensitive, with confidence intervals that dipped as low as 89.8, which suggested that you could be missing up to 10% of subarachnoid hemorrhages within the 6-hour window. So in this study, they had 111 patients with subarachnoid hemorrhage, and 5 were missed on non-con CT. So who did this study miss? So 2 of the patients in the study likely did not end up having a subarachnoid hemorrhage. So they had unruptured aneurysms on the CTA and thought to have had a traumatic tap, and they were deemed not subarachnoid hemorrhage by neurosurgery. One subarachnoid was a true miss by the radiologist. One patient had a non-aneurysmal subarachnoid hemorrhage from a dural vein fistula, and one patient had profound anemia with a hemoglobin of 63 and had sickle cell disease. So the trial reminds us of some important considerations in the diagnostics of subarachnoid hemorrhage. So number one, as we saw in the false positive cases, the CTA and the LP can actually lead to some confusing results and muddy the waters diagnostically. And we're going to talk about that in the next sections. Number 2 is that mistakes happen. Radiologists are incredible diagnosticians, but they're human and they occasionally miss subarachnoid hemorrhage. And number 3 is anemia makes subarachnoid hemorrhage difficult to diagnose on CT. And you can't rule out subarachnoid hemorrhage on a non-con CT if the hemoglobin is less than 100 or the hematocrit's less than 30%. So the big question is a 4.5% miss rate good enough? And I would say in most cases, it probably is, especially if the patient is low risk to begin with and you're using a modern CT scanner and it's radiology red. And I'll use Bayesian theory again to prove this statement. So with a 95.5% sensitivity and specificity of 100%, the negative likelihood ratio for non-con CT under 6 hours is 0.045. Many sources actually say it's actually 0.01. So I'm being very conservative, and that's what the calculator has it as 0.045. So let's consider an example. So say we have a patient with isolated thunderclap headache. Recall they have a 7.5% chance of having a subarachnoid. So after a negative CT scan done within the 6-hour window, the chance of that patient having a subarachnoid hemorrhage using the negative likelihood ratio of 0.045 is 0.4%. And you can try that on the online calculator if you like. So that's very good. And I think most people would consider that acceptable for rule out. So let's think about our case though. Recall she presented after 6 hours, but let's hypothetically say she presented before 6 hours. So she had a pre-CT probability of 35%. So after a negative non-con CT using a negative likelihood ratio of 0.045, her chance of subarachnoid is 2 to 3%. So still a little bit high. But if her pre-CT risk had been lower than 20%, that would give her a post-test probability of less than 1%. So the bottom line is that a negative non-con CT under 6 hours on a modern scanner in radiology red can rule out subarachnoid hemorrhage if pre-CT risk is low, under 20%. Now let's talk about CT after 6 hours of headache onset, or what I like to call tiger country. CT sensitivity decreases with time and is less accurate after 6 hours, with reported sensitivities that range between 86 and 93%. But there are a few issues with these over 6 hour cohorts. So in these over 6 hour cohorts, we're dealing with spectrum bias and heterogeneity. So let's talk about spectrum bias. So because of how subarachnoid hemorrhage presents with a thunderclap headache, people who have real thunderclap headaches don't tend to take their sweet time to get to the emergency department. So what happens is that patients who present under 6 hours tend to have a higher incidence of subarachnoid hemorrhage. So in the Perry 2020 study, the incidence of subarachnoid hemorrhage in patients presenting under 6 hours was 9%, but after 6 hours, it was only 3%. So it actually makes the pretest probability of subarachnoid hemorrhage lower for thunderclap headaches presenting after 6 hours. So next is heterogeneity. The over 6 hour cohort is quite a heterogeneous group, where sometimes these patients are presenting days after headache onset. In the original Perry 2011 study, where no subarachnoids were missed under 6 hours, all the patients that were missed actually presented after 8 hours of headache onset. And in the other time-dependent CT study, which is a study by Bacchus in 2012 in stroke, all the missed subarachnoids on non-con CT actually came after 27 hours they presented after symptom onset. So let's put things in perspective. The negative likelihood ratio for CT over 6 hours from the Carpenter paper is 0.07. So let's apply this. Say we have an isolated 1 hour to peak headache. So remember, that gives us a probability of 7.5% chance of subarachnoid. But really, it's probably lower than that because these patients are presenting after 6 hours. They're usually less prevalent. But let's use 7.5 just to be ultra conservative. So using a negative likelihood ratio of 0.07, the post-test probability is 0.9. So I would say that's still under 1%. That is probably acceptable for ruling out. If we have the patient from our case, remember she presented 7 hours, she got her scan 7 hours post-headache onset. So her pre-CT probability was 35%. Using a negative likelihood ratio of 0.07 puts her at a post-CT probability of around 4%. So she would require further workup. So the bottom line is CT after 6 hours is good, but not perfect. And it likely can be used as a rule out in ultra low risk patients. So with a pre-CT risk under 10%. So in summary for non-con CT, a negative non-con CT under 6 hours can be used as a rule out if a patient is low risk. The sensitivity is not 100% as it was in those blissful years between 2011 and 2016, but it's still very good. If your pre-CT probability is over 20% based on clinical features, your post-CT probability will be over 1%, and you should consider further diagnostics, which we'll talk about next. After 6 hours, the data is not as robust, the sensitivity is lower, and the patients are heterogeneous. In certain instances, in ultra low-risk patients, essentially with isolated thunderclap headache, a negative CT over 6 hours can be used as a rule out. This recommendation, though, would be considered controversial, and clinical guidelines still recommend an LP in this group. So our patient, her non-con CT head returned normal after 7 hours post-headache onset. This makes her probability of subarachnoid 4% at this point in the workup. So we're still worried about subarachnoid after this negative non-con CT. So what are our options now? Let's have a little peek at the menu. So first we have the lumbar puncture, which is a classic. It's a tad invasive and may cloud the diagnosis. It also may make your headache worse with a post-LP headache. Then we have the CTA, which is quick and easy. There is a roughly 3% chance, maybe higher, that we'll find a non-bleeding aneurysm, and we won't know for sure if it's the cause of your headache. You may end up going for unnecessary neurosurgery or knowing that you have an aneurysm may cause you stress for the rest of your life every time you get a headache. Also, if the CT shows an aneurysm, you'll need an LP anyways. Then we have shared decision-making, which is where we discuss the risks and benefits and make a decision together. Sometimes this will mean doing no further testing. Then we have the elusive MRI, which unfortunately is not available at this time. But seriously, we won't spend too much time on it in this discussion. It's rarely a practical option in the emergency department due to availability, and the performance is comparable to CT scan early on. So let's discuss the LP. There are many controversial topics in this section. The first question we'll ask is which patients should have an LP? Second, the pros and cons. Third is how accurate is xanthochromia in the diagnosis, and how to interpret red blood cells in the CSF. So as we decided in the previous section, patients with pre-CT probability over 20% with a negative non-con CT under 6 hours, or patients with pre-CT probability over 10% with a negative non-con CT over 6 hours should have an LP considered as a next step in their workup, assuming the patient doesn't have any contraindications to the LP. So the AHA guidelines from way back in 2012, which have not yet been updated, still recommend LP after negative CT for all patients with suspected subarachnoid hemorrhage. It sounds like these are, in my communications with Dr. Carpenter, it sounds like these guidelines are being updated. Most other resources, like UpToDate, recommend LP for moderate to high-risk patients with negative non-con CT under 6 hours, similar to the message I'm presenting today. So there's a small subset of patients where an LP would be considered very beneficial. So these would be patients with anemia, so hemoglobin less than 100, as they have a much higher risk of false negative CT scan. Patients with significant delay between the headache onset and CT. So the late presenters, LP is definitely a good test because the sensitivity of CT goes down with time, but the sensitivity of LP goes up. And those patients who have diagnoses that would be that could be diagnosed with an LP. So patients with suspected CNS infections or patients with suspected pseudotuber cerebri would benefit from an LP. So the decision to LP would be a lot easier if the test gave us a precise answer. But unfortunately, the results of the LP are often uncertain. And because of this, there's been a lot of debate recently in the research world and the full med world about the utility of the LP in the workup for subarachnoid. So Dr. David Newman from the SmartEM podcast calculated the number needed to LP to diagnose one subarachnoid hemorrhage that required neurosurgical intervention and found that to be 700. There was a study in the UK in 2015 by Sayer and colleagues that also calculated the number needed to LP to diagnose one subarachnoid hemorrhage and found it to be 250. So with the known risks of the procedure and the sequelae of an indeterminate LP, we really must consider the pros and cons. So let's talk about the pros and cons of the LP. So personally, I like doing LPs. I find them to be a nice procedure. And best case scenario with the LP, you either get clear fluid that suggests a negative workup or obvious xanthochromia that suggests a positive, and then you're done. And the picture on the right depicts the difference between these two findings. But it's really not that simple because up to 30% of the time when you do an LP, you'll have a traumatic tap where blood is introduced into the needle from somewhere outside the CSF. And traumatic taps can lead to confusing diagnostics and potential false positives. So for example, in the 2015 Perry BMJ study on traumatic tap versus subarachnoid hemorrhage, 1,700 patients in that study had LPs. Out of those patients, 37% had either blood or xanthochromia in their CSF. Out of that 37%, only 2% of those patients were ultimately diagnosed with aneurysmal subarachnoid hemorrhage. So that really highlights the number of false positives that we get with LPs. LP complications are common. For example, post-LP headaches occur in up to 15% of patients. There are also many other complications with LP, like meningitis, epidural hematomas, nerve root damage. LPs are time-consuming, especially in a busy emergency department, especially in a place that has only single coverage. And the final issue is patient refusal of the procedure. Some patients, when you present the idea of an LP, will refuse the procedure. This is where shared decision-making becomes important on whether or not to pursue other diagnostics like a CTA. So now let's discuss xanthochromia. So as we know, xanthochromia is the pathognomonic finding for subarachnoid hemorrhage on LP. After subarachnoid hemorrhage, red blood cells are broken down into oxyhemoglobin and bilirubin and contribute to discoloration of CSF. Xanthochromia in the CSF has a very high positive like-good ratio of 15 for ruling in subarachnoid hemorrhage. So the presence of xantho is a clear positive for subarachnoid hemorrhage. The absence is also strongly suggestive to rule out subarachnoid hemorrhage with a negative like ratio of 0.3, especially in combination with negative non-con CT. But the CSF must also be sent off for red blood cell count as well, as we'll talk about. So we know that the formation of xanthochromia takes time, with 12 hours being a commonly cited number. So theoretically, if you did an LP too early, that could result in a false negative result. Some older papers have recommended that LP be delayed 12 hours to ensure an accurate result, but that recommendation has never made it into guidelines. So one of the big issues with xanthochromia is that it's measured differently in different parts of the world. which makes it comparison across different studies quite difficult. So in North America and in Calgary, xanthochromia is simply measured by visual inspection of the CSF against a white piece of paper. So it's pretty high-tech stuff. But in European hospitals, they use spectrophotometry to evaluate the presence or absence of xanthochromia. The good news, though, is that spectrophotometry doesn't appear to be any better than visual inspection at ruling in or ruling out subarachnoid hemorrhage. So in addition to xanthochromia, CSF should be analyzed for RBC count regardless of the timing of the LP. So how does red blood cell count in the CSF alter our suspicion for subarachnoid? So recall that up to 30% of LPs will have some amount of blood on them from either a traumatic tap or a subarachnoid hemorrhage. So older studies have tried to look at the number of red blood cells in tube 4 or the decrease from tube 1 to tube 4 to try and determine a cutoff for what determines subarachnoid hemorrhage versus traumatic tap. The general rule is that the greater number of RBCs in the final tube, the greater the chance of subarachnoid hemorrhage. So in the 2015 Perry paper we discussed looking at traumatic tap versus subarachnoid, recall that 1,700 patients who had an LP, recall that there were 1,700 patients that had an LP and 37% of those patients had either blood or xanthochromia. So out of the patients that had blood on their CSF, the vast majority of those were traumatic taps. Remember, only 2% of those were subarachnoid hemorrhage. So the patients with subarachnoid hemorrhage had a lot of blood in their final tube, with a median of 20,000 cells in red blood cells in their final tube of CSF. Whereas the patients without subarachnoid hemorrhage only had a median of 20 cells in their final tube. So what is the cutoff to differentiate trauma versus subarachnoid hemorrhage? So less than 2,000 red blood cells in tube 4 had a sensitivity of 93% for ruling out subarachnoid. If there was no xanthochromia, in addition to under 2,000 red blood cells, the sensitivity increased to 100%. So to summarize, no xanthochromia and less than 2,000 red blood cells in tube 4 rules out subarachnoid hemorrhage. More studies on this would be nice, but this study was consistent with retrospective studies that have been done on this question as well. This recommendation has not yet made it into the guidelines. So in summary for LP, the utility of the LP has been debated recently and has a very high number needed to LP to diagnose a subarachnoid hemorrhage. And the LP has a high number of complications and false positives. But despite not being a perfect test, it remains an important part of the diagnostic workup after CT scan due to its high specificity for xanthochromia and blood in the CSF. Xanthochromia rules in subarachnoid, and the lack of xanthochromia plus a negative non-con CT rules out. But we still need to send for a red blood cell count as well to rule it out definitively. Suspect subarachnoid hemorrhage if you have a high number of RBCs in the final tube, and no xanthochromia in less than 2,000 RBCs in the final tube rules out subarachnoid hemorrhage. The positive and negative likelihood ratios for xanthochromia and red blood cell count can be found on the online calculator. Okay, so back to our case. We performed an LP. We had a traumatic tap with blood-tinged CSF in tube 1 and clear CSF in tube 4, and no xanthochromia. So the CSF was sent off and found 1,000 RBCs in the tube 1 and 30 RBCs in tube 4. So no xantho and less than 2,000 RBCs in tube 4 rules out subarachnoid hemorrhage in this patient. She now has almost a 0% risk of subarachnoid hemorrhage. So we've ruled out subarachnoid hemorrhage with the classic non-con CT plus LP approach, and we're feeling pretty good about it. But let's take a step back. Why did this young female have a thunderclap headache? Subarachnoid hemorrhage is not the only diagnosis on the differential. I'll be honest, in real life, I think most of us, including me, probably would have ordered a CTA on this patient instead of an LP to rule out other worrisome causes of thunderclap headache, such as RCVS, stroke, CVST, cerebral or vert dissections. So that brings us to the next section of the talk, the CTA. The CTA is when a simple click of a mouse can tell you if your patient has an aneurysm. For some patients, the decision to CTA is simple. So patients with a positive non-con CT or patients with positive LP will go on to get a CTA to look for the aneurysm. Recently, there's been suggestion of using CTA as a replacement for LP in the diagnostic workup for subarachnoid hemorrhage. It's important to realize the non-con CT and the CTA are looking for very different things. So the non-con CT is looking for blood, but the CTA is an anatomical test looking for the presence of an aneurysm. It doesn't tell you with certainty if it's bleeding or not, though. The CTA has a lot of draws as a replacement for LP in the workup for subarachnoid. It's fast and easy for us in the Emerge. It's much less invasive than the LP and much more likely to be well received as an option when you present it to patients. Recall that 80% of subarachnoids are aneurysmal. CTA has a sensitivity of 98% and 100% specific for detection of aneurysms that are over 3 millimeters. And in general, larger aneurysms tend to be much more likely to bleed. So negative CTA, when coupled with a negative non-con CT, has a post-test probability of subarachnoid hemorrhage of less than 1%. As I said before, the CTA has the added benefit of diagnosing other very important causes of thunderclap headache that should be on our radar, like RCVS, stroke, and dissections. And it also would be the test of choice if a patient refuses an LP or has a contraindication or will be a challenging LP. But let's talk about the not so good aspects of CTA in the diagnostic workup. So CTA can miss small aneurysms with a sensitivity in the mid-80s for this size. And these aneurysms are much less likely to, but can still bleed and have devastating consequences. For aneurysms larger than 3 millimeters, the CTA is extremely sensitive, but it doesn't tell you if that's the cause of the headache. And that's a big problem because the chance of finding incident aneurysms is high, reported between kind of 3 and 7%. 3% seems to be the most agreed upon number. And the finding of these incidental aneurysms can cause two issues. The first issue is these aneurysms can be interpreted as culprit lesions and undergo dangerous neurosurgical procedures. Secondly, there may be a psychological burden to the patient knowing about the presence of an aneurysm, which may cause them to worry about subarachnoid hemorrhage every time they have a headache in the future. So if an aneurysm is discovered on CTA, an LP will need to be done anyways to determine if it's incidental versus symptomatic. So in a way, you're kind of back at square one needing the LP. So in summary for CTA, reflexively doing a CTA after a non-con CT can lead to neurosurgical interventions, as well as turning people into patients, knowing that they have an aneurysm. As we know, the CTA is the next step after a positive non-con CT or positive LP, and very helpful in making sure we're not missing any important other things on the differential diagnosis for thunderclap headache. So where do I stand on the CTA versus LP debate? So for me, the LP is still the gold standard. If subarachnoid hemorrhage is the diagnosis that needs to be ruled out, it's very high, it's the top of the differential, especially in a high-risk patient under 6 hours or a late presenter, LP will be my go-to. I will use CTA on patients with a differential diagnosis for thunderclap headache is more broad, or there are contraindications to the LP. Of course, we talked about there will be patients that end up getting both tests, but in general, the combination of a negative non-con CT and a negative LP, or a negative non-con CT and a negative CTA, are both considered the gold standard in ruling out subarachnoid hemorrhage. An important factor in our decision-making will be patient preference. So when we look at the algorithm, there are a few moments where shared decision-making will be an important factor on what we do next. The first is when we're faced with a negative non-con CT in low and medium risk patients. I think for ourselves, we need to determine a cutoff in terms of risk of missed subarachnoid hemorrhage we're willing to accept. And I've shared mine, and it's under 1%. That's knowing the current miss rates and the mortality and morbidity of subarachnoid hemorrhage, and also considering the risks of false positives that can come from an LP and a CTA. Then we can share these numbers as well as the risks and benefits of further workup versus no further workup with patients and document that conversation. The second shared decision-making moment shows up in the LP versus CTA decision. Again, patient presentation factors and risk calculations will go into this decision, but patient preference should be factored in as well. And my hope is that the online calculator will help frame conversations with patients to provide some clarity in helping know their risk of subarachnoid hemorrhage. Okay, so let's bring it all together in one final summary. So consider the diagnosis of subarachnoid hemorrhage in patients with thunderclap headache, so 1 hour to peak headache or worst headache of life. This will ensure we're not missing any patients with subarachnoid hemorrhage. You can apply the Ottawa subarachnoid hemorrhage rule, and if you're lucky, it will screen negative and you've ruled out subarachnoid. If the patient is Ottawa subarachnoid rule positive, be more suspicious of the diagnosis, as these features have high positive likelihood ratios. Use the calculator to assess your pre and post negative non-con CT probabilities. Negative non-con CT under 6 hours will rule out subarachnoid in the majority of low and medium risk patients. Non-con CT over 6 hours can sometimes rule out subarachnoid hemorrhage in ultra low risk patients. This is a somewhat controversial statement that needs more study and expert input, but when in doubt, perform the LP or the CTA. In the remainder of patients, further diagnostic testing is indicated, so an LP or CTA. LP will be my test of choice if subarachnoid hemorrhage is high on my differential diagnosis with low suspicion of alternate etiologies. CTA will be my test of choice if I'm considering alternative diagnoses or have contraindications to LP. Shared decision-making will factor into my decision after a negative non-con CT or whether or not to CT or to CTA or LP. So here's the full proposed algorithm that I've created, and I'll post it in the chat in just a sec here. But my hope is that this algorithm can undergo further review, so I'm happy to hear any feedback. Also, there's the QR code there to the online calculator for reference. So with that, I'd like to say thank you to the following people for all their help with this talk, and I'm happy to take any questions.
Thank you for all of your hard work on this talk, Sean. That was fantastic. We do have a couple of questions here, so I'll just kind of work through them. The first one is from Dr. Aaron Johnston. Does the lab here in Calgary use formal colorimetric assessment for xanthochromia, or do they just use visual inspection?
As far as I understand, the report that comes on the results comes from visual inspection. There's no spectrophotometry used in Calgary.
That's my understanding as well, Sean. I'll also tag on here, there was just another kind of separate question that was asked around other potential false positives for xanthochromia. So Dr. Morris pointed out that, Dr. Lise Morris pointed out that with severe hyperbilirubinemia, so severely jaundiced patient, you can have a positive xanthochromia on the CSF as well, but typically that happens with bilirubins over like 70 to 80, so fairly severe. Yeah, hyperbilirubinemia. From Dr. Catherine Patoka, just when considering CTA versus LP, worth noting that there is a fairly significant chance of other incidental diagnoses that we can find. Dr. Patoka and one of the University of Calgary medical students, Logan, with Dr. Eddie Lang, are working currently on a CTA study looking at kind of incidental findings versus positive true findings. And the incidental finding rate can be as high as 40% that they're finding. And just to remember as well that the baseline asymptomatic aneurysm rate in the population is thought to be, as you mentioned, around 2 to 3%. She does have a question for you, Sean. How important is it for us as emergency physicians to diagnose RCVS, or reversible cerebral vasoconstriction syndrome? I have seen neuro consider it in follow-up and was not under the impression that this was an emergency diagnosis necessarily unless they were having focal neurologic deficits.
Yeah, that's a good question. And I asked this question to a couple of my neurology colleagues as well, because it wasn't on my radar as much until recently, because it's been recently. It was basically the diagnosis was described just in 2007 actually is when it first was described, and there's a long list of previous things that caused a similar syndrome, and they basically unified it to for the literature so they could start studying this big group of disorders. And when I asked the neuro colleagues about this, like RCVS is more common than I thought. I don't have a number, but it's on up to date. It's number 3 on the causes of on the likelihood causes for thunderclap headache, and they do actually neuro does admit most of these patients with RCVS to start them on calcium channel blockers. So because the risk of complications, seizure, stroke being the 2 main ones, is not that insignificant. It's around 10 to 15%. So they are admitting some of these patients. I think there's definitely some low risk ones they wouldn't, but yeah. And the other thing about RCVS that's interesting is that it's not the easiest diagnosis to make on CTA. I think only early on is when you can catch it. I think if it's a chronic thing, it doesn't often show up on CTAs, from my understanding.
Yeah, and I'll corroborate that as well, Sean. I agree with Dr. Patoka when you're kind of weighing the balance of an RCBS diagnosis versus potential other incidentals that may be found. I don't know that this is necessarily within our wheelhouse as emergency physicians to make this diagnosis on our own. Certainly, I think there's a lot of value to involving our neurology colleagues to help guide that decision making. And in terms of kind of prompts for whether we might consider bringing patients in, would be severe refractory headache that we just are not controlling potentially, and then potentially focal deficits, which would show up as well, as Dr. Patoka had pointed out. Next question is from Dr. Jennifer Putty. Are you able to clarify the units that RBCs are reported in the Calgary CSF? Some of the podcasts like EMRAP are suggesting RBC less than 50 in an LP as negative, but the units may be different.
The units are the red blood cells per, I can't remember the unit for size. It's, I don't want to give the wrong number, but the units that I described were the same as the units that we would use it locally. I'm not sure what MRAP is using as units, but I'd have to look into exactly what units per field, how big that field is. But I think that the 2000 rule works in Calgary.
Yeah, that's my understanding as well, Sean, that's the number that you've pulled is directly from the Jeff Perry paper.
Yeah.
Okay, those are all of the questions that we have got here. Unless there are any further questions, I think we'll wrap it here. And thank you very much, Sean, for your presentation today. I will hand things over to Dr. Neil Collins and Dr. Sean Dowling here.
Thanks.
Hey, thanks very much, Sean. That was really good. And Katie, that was a perfect example of some great information that might wind up on the My Emergency Department app and website sometime. So we just wanted to go through this, folks, for those of you who aren't familiar with it, and just to give those of you who've been using it already just some context for this initiative. So this was kind of born out of some necessity over the past several years to warehouse our departmental protocols and some local practices. And then Sean came up with this idea for having this using a commercial website that had an app associated with it to save us some work. And I think it's really worked out well. It's pretty smooth. So I just wanted to give you guys a sense of how we're using this as departmental administrators. There's the medical literature, and then it's how it's interpreted. For a perfect example is Sean's talk right now. We're all up to speed on diagnosis for subarachnoid hemorrhage, but how that interacts with our local resources and what our neurosurgeon colleagues think of this is sometimes different. So what we wanted to do was have a site where the resources were academically up to date, but also smoothly interacting with our consultant colleagues. So I'll give you an example. Sometimes there are problems identified that are years in the making. Either we're not making the diagnosis often enough, or we're overdiagnosing and overconsulting specialists. So an example would be the spine service. They were a bit frustrated with the number of consults they were getting, not just from us, but around the province for some spine emergencies, especially spinal epidural abscess and cauda equina syndrome. And they wanted us to revise our referral practice. We wanted to be more clear with them about who they would take in referral, when they would see them, and also interact with radiology. So we developed a spine protocol. A number of us worked on that, and Pandya for sure was a major force in that. And we developed these policies with spine, and they agreed with them, and they agreed to abide by them. So when you call at 4 o'clock in the morning from Peter Lougheed Hospital, you can be sure of the indication for your spine emergency, and it's been pre-agreed upon with the specialist. So that's one example of something that's available on the app and website. Sean's going to go through the organization of it and just a few examples of what else is available there, just for people to have a look at. But I just wanted to kind of introduce it. So I guess what I'm trying to say is not only is our information available there for your convenience, but the specialists that you're referring to will sometimes have an expectation that we will have referred to departmental policies before consulting them for a few of these indications for consultation. And those policies will be available on the website and app. So make sure you're familiar with it and you have an idea of what's on there. So we're going to go through that now. And I'll turn it over to Sean.
Great. Thank you, Neil. I think hopefully everyone can hear me okay. Neil did a really good job of describing what this app and website is meant to be. It's really another knowledge translation tool. Unfortunately, we can't change practice solely by changing SEM order sets. This tool provides us a way to have more consistent awareness of what the various guidelines are and the different protocols that have been developed in the department, and hopefully improve our knowledge translation and improve the quality of care that we deliver. So I have no financial disclosures. As Neil said, this is a commercial app, but we pay them money. We don't get anything from that from them otherwise. I have to thank the Physician Support Fund because they funded this in conjunction with the Children's Group, who funds their side of the app. So that's been fantastic. And I'd be remiss to not thank Hillary and Kate for all the PEDS content, as well as developing the videos on how to register and some of the tips and tricks. They've been very committed to doing this, so it's been fantastic. So really, as Neil mentioned, I'm not going to go through this too much, but other than to say, lots of work has been gone into developing various protocols and pathways and resources within our department. And in the past, we all know how infuriating it's been to try to find these various resources, whether you're trying to find it on Insight, which is, impossible to search, whether we are trying to identify one of the various websites that our department had. It was always a constant challenge. And as a result of that, I think people sometimes were defeated and didn't bother searching. So what is the MyID app in essence? It really is a readily accessible repository of relevant emerge information. And Neil's talked about the pathways and guidelines already. But it also is increasingly a repository for all the relevant information we need to do the job that we do. So referral forms like the early pregnancy loss clinic referral form, all the various sports medicine clinics. Miles Hunter's gone through and developed documents to talk about all the relevant sport medicine groups in the community, as well as what their area of expertise and all the referral forms. So it's a fantastic resource and really is value added from that perspective. From a pathways perspective, we'll show you the troponin one in a few minutes, the infected stone pathway, all the urology pathways are on there. We've worked with PADIS to have all their guidelines incorporated into the MyID app as well. So you have this one site for all those PADIS guidelines. There's a patient handout section, aka the patient leaflets, and I'll show you that later, which is a very novel tool. And then we have the online links to various tools that you need. So if you need the MD Calc, there's a connection there. The HAC impairment index that Jen Nichol's been working on recently to use for clinical sobriety. You can find that there, as well as the VIPIT algorithm, which we'll show in a few minutes. So there's really two ways to access it. We often refer to it as an app, which you can find by going to either App Store or Google Play and searching my emergency department. Or there's also a website, and we'll show you that functionality in a few minutes. And that website will soon, we're just going through the final steps of this, hopefully, but it'll be available on your Sunray desktop. So when you log in, when you swipe your card on that desktop, you'll have the My Emergency Department app there, which has some increased functionality in terms of being able to print things directly from the app or the website. So I'm just going to take a quick minute to go through. I've looked through the attendee list, and many of the attendees here are already logged or signed on with My Emergency Department app, but there's some that aren't. So I thought this would be valuable to do here. So first thing you'll see when you go to myemergencydepartment.com is this welcome page. And if you search Calgary, you'll get two options here. There's the pediatric emergency medicine site, which for anyone who does adult and peds, you don't need to be a part of that. Any of the relevant pediatric emergency practice guidelines or information is on the adult one. The Calgary Zone Pediatric Emerge one is for PEM stuff relevant specifically to the children's. So you'll go here, you'll need to log in, and hopefully it's successful. That means you remembered your password. And you'll see this is sort of the main page here. You can see the various different categories throughout here. It is not that useful to try to search things through these various categories. And there's a couple of reasons to that. There's technical issues with us putting links to certain documents and PDFs and PowerPoint presentations that we can't put into certain sections. And the more important barrier to categorizing our protocols and stuff into these different categories is, as you can imagine, subarachnoid hemorrhage, for example, would be a good example of something that may fall under neurology, it may fall under neurosurgery, it may fall under critical care. So rather than trying to lump these things into various categories, the best way to search for something is using this master search function here. So if you click master search, you'll come to search everything. And the first pathway I want to show you is the troponin pathway. So if you click search there, you'll see troponin high sensitivity pathway for the relevant Calgary sites. We've also included the ones for urgent care and rural hospitals in case you're getting a referral from somewhere else. So you'll click on it here, and this will bring up the troponin pathway that's been developed locally by James Andruko and Andrew McRae, validated in Calgary. And it walks you through the diagnostic approach to interpreting troponins, high sensitivity troponins in patients with suspected ACS. So it talks about your various cutoffs, ruling in, ruling out. If you go down to the bottom, it also has the heart score calculator in there and all the relevant information that you need. So an absolutely fantastic resource available either on the app or as well as on the website. The next thing I want to show you is recently, Tasha Wright has done some, Dr. Wright has done some work with urology around the STI diagnosis and treatment pathway. It's not done with urology, but she's done some work based on the provincial guidelines and created a nice 2-page synopsis on how to diagnose and manage sexually transmitted infections. And this aligns with all the order sets, as well as our sort of local practice patterns in terms of how to investigate these patients or patients with suspected sexually transmitted infections. You can also see we've included the cheat sheet in terms of which test you're supposed to use. If it's, if you're checking for gonorrhea or chlamydia, when you're checking for males or females, when you're checking for BV or yeast, as well as when you, if you're needing to use the HSV or VZV swabs. So all those resources are found on there. Now, another thing that some of you may be familiar with, if you read your recent email from Dr. Walker and Dr. Lendrum on the Foothills update, including the recent vaccine-induced prothrombotic state with COVID vaccines. And you can come here and find the diagnostic pathway for VIPIT in patients with post-vaccine complications. So really all these resources are readily available both on the app as well as on the app, as well as on the website. Another really cool component to this is the patient leaflets. So on the app, this only works on the app because, as you can imagine, you can't bring your desktop computer, your laptop computer to the bedside. But when you search one of the patient leaflets, you'll find the various discharge instructions that we provide patients. I didn't appreciate when we ask a nurse to print off a head injury discharge information sheet. If you actually look on My Alberta Health, which is where they go to do this, there's about 10 different options because there's concussion, there's adult, there's peds, there's post-concussive syndrome, there's post-neurosurgical, there's actual traumatic brain injury. So there's a huge number of resources that are out there. And I didn't realize how variable it can be in terms of what they print off. So what we've done is sort of taken those resources that are relevant for the emergency department, and my daughter gets paid to download these various things onto the app so that we can have access to them there. And what you do is you hold up your phone with a QR code and the patient holds their camera over top of it, and it downloads that discharge instruction automatically to their phone. And patients love this. And it actually helps, save the nursing significant amount of time and decreases confusion as to which discharge instruction you want. The two barriers are, one is patients either need to have cell connection or be connected to the Wi-Fi for this to work. And then the second thing is not all Android devices have a QR code reader built in. So if those are potential limitations. If that happens, you can just print off the discharge instructions either from your desktop through the app or speak to the nurse and have them print it off like we've done traditionally. So quickly go through a couple of frequently asked questions. People have often asked how I print something, if it's a referral form or discharge instruction sheet. That needs to be done from either your laptop if you're connected to the printers, which most of us aren't, or you can log into the website, the My Emergency Department website, and you can print it off from there. The second thing you may come across is occasionally, if you're linking to one of the resources that's part of Insight, it'll ask you for your AHS login, which is the same one you use to log into the desktop computers. Usually you get a login persistence through a whole shift. So if you log in once, you should be able to log in for the rest of the shift. And that will allow you to access all those relevant Insight documents. And the reason we've done that is so we don't have to continuously update the documents. The Insight's a source of truth, and we can link there in the future. And then finally, some of you may still wonder how you register for it. If you scan this QR code here, it'll bring you to a video that Katie Anker created and walk you through the steps to log in, or you can just email myself. So in conclusion, the product, this app and website is only as good as the content. So if you have any suggestions, feedback for content, or feedback on the website itself, please let us know and we're happy to include it. If you're interested in being involved in this in any capacity, either with the discharge instructions or working on any of the pathways, please email myself or Neil and we're happy to get you involved. Because, when Neil and I first started talking about this project, I kind of envisioned this nice little project to bite off, and it's become a lot more work than I anticipated, but it's been super valuable, and the feedback from colleagues on shift has been that it's a good resource, so it's well worth the effort. So open it up to any questions. Neil, I don't know if there's any question. It doesn't look like there's any questions. If there's any comments or anything.
Yeah, that's great, Sean. Thanks. And I just want to add one thing. So just as another example of a pathway, potential pathway. So ENT reached out through, the program director reached out to Catherine Patoka and said, our residents are getting hammered with certain consult calls in the middle of the night. Do you think we could, provide an educational opportunity for your group to sort of smooth out consults? And that prompted sort of an email introduction to myself. And so basically what happens is I get a couple of volunteers who have already lined up. They interact with the ENT surgeons. It takes a couple of months of trading emails, reviewing the literature, reviewing local practice and clinics, and then they come up with a pathway. So sometimes the necessity for these pathways is introduced by the specialist. Sometimes it's from our point of view. So if we're having confusion, if there's differences between how things are handled across the zone, then we want to hear about it. So, please, if there's anything that you think would benefit from a pathway or further clarification, then let Sean or I know, and we'll try and interact with the appropriate specialists and get a pathway going or get clarification on the website. So any opportunities for improvement of zone care of our patients, we'd be happy to look at it. So Sean,
there's one quick question from Ryan Chung about he's searching and can't find the sports medicine clinics. There's one little bug in the program in that people who signed up very early may still be logged in under Foothills. So when you first log into the app, if it says Foothills at the top of your app, welcome to Foothills instead of CEM, you actually don't have access to any of the new resources on there. So you need to log out and re-log in, and then you'll have access to the newer stuff. But again, if you go to master search sports medicine, you'll see all the various referral forms as well as sort of the master guide that Miles Hunter has created. All right, unless there's any additional questions or comments, I think we're done from that perspective. Thanks, everyone.
Yeah, thanks everyone. Round's over.